accepted, and we'll just give that a second while that goes live. I'll let you know, Chair, when it's live. We're good to go now, Chair.
Morning, everyone, and welcome to the 21st of October. Just before we start, there is a slight change in the order in which we're going to do the agenda today. So just note that Michael Horton does have to leave early today. So item number 9, the community eye care service, we're going to do that after we've approved the minutes, if that's okay with everyone. Ewan.
You're not too loud, Ian. You're quiet.
Can't hear you, Chair.
Is that better?
That's a lot better.
Yeah. So item number 9, Michael Horton needs to leave early, so we are going to move that item to straight after the minutes have been approved. Okay. Brilliant. So if Hannah, if we could do a roll call and do attendance, please, first, that'd be great.
Okay, so when I call your name, please just confirm that you are here. Councillor Bell.
Yep, here.
Councillor Donoghue.
Here.
Councillor Dr. Chow. Councillor Heslop.
Here.
Councillor Layton. Councillor Lee.
Here.
Councillor McEwen.
Here.
Councillor Newell.
Here.
Councillor Tostevin.
Here.
And Councillor Wright.
I am here.
Thank you. We've also got Miriam Davidson, Pauline Mitchell, Michael Horton, Jennifer Illingworth, Christine Shields, and Jeanette McMain.
Great. And I believe everyone knows each other, so I don't think there's any. Is there any need for introductions? No. That's great. Okay, so we can move on to item number 2, declarations of interest. I'd just like to say that I am bank healthcare assistant for the trust, Durham and Darlington. Councillor McEwen.
Yeah, I'm a lay member of Darlington Primary Care Network governing body.
Yeah. Councillor Tostevin.
I'm on the board of governors for County Durham and Darlington Foundation Trust.
That's great. Any further declarations of interest? No. That's fine. Okay, so if we could move on to item number 3, if we could approve the minutes of the meeting of the scrutiny that was held on 2nd September 2020, it's page 1 to 4 to start with. Is everyone happy with the minutes? Anyone got any amendments they would like to make? No, do I have those seconded?
Second.
Brilliant, thank you. Item 3B, the minutes from the 9th of September 2020, pages 5 to 6. Any amendments anybody wishes to have made? Okay, we're happy to sign those off. Any seconded? Everyone happy with those?
Yeah.
Brilliant, thank you. So if we can go on to item number 9, which is community eye care service, Michael Horton to present. These are pages 47 to 48 in your packs, if you have received them.
Thank you, Chair, and thanks for the change to the agenda as well, which is really helpful. Just in terms of this paper, it's fairly brief. We've Tees Valley CCG and County Durham CCG have awarded a contract to Primary Eye Care Services Limited, and this is really about post-op follow-up for people who've undergone cataract surgery. The aim of this really is to move follow-up care for people who have had cataract surgery out of hospital and make the pathway more accessible for residents of Darlington. So the aim is that patients who've had a cataract operation would receive their post follow-up care out in the community. So this particular service will be delivered from high street opticians within Darlington. and the service itself will be obviously provided by qualified practitioners and clinicians in accordance with NICE guidance. This service was due to start earlier, and you might remember we brought a paper a while ago, but the exact time it was due to start, which was April, was when the COVID pandemic had come. So that's why there's been a slight delay in actually awarding the contract and mobilising the service. But this paper is just to really advise the committee that that's now all happened, and the service is now in the process of being implemented across Darlington. So that was really the aim of the paper, Chair. Thank you.
That's great. Thank you, Michael. Does anyone have any questions for Michael? No. That's great. Well, thank you for joining us this morning, Michael. I know you're very busy.
No, thank you very much.
I know you've got to
thank you.
due to certain circumstances. So yeah,
Yeah.
You can go if you'd like.
Okay, thank you, Chair. Thank you very much. Bye now.
Thank you. I would like to welcome Sue Jacks to the meeting, who's joined us. So welcome, Sue. If we can move on to item number 4, which is the local outbreak control plan. Miriam, I believe that you're going to give us a verbal update on this.
Yes.
We decided not to put papers in because it is forever changing, and we didn't want you to have out of date. So Miriam's going to present to us on the day, if that's okay with everybody.
Thank you. I really appreciate that, Chair. Given the long lead-in time, it would have been quite out of date by the time we'd come to it. So I do appreciate that, and thank you also. Paul's going to whip through the slides for me, of which I don't have hundreds, to be fair. So let's go to slide 2. Thanks, Paul. Yep, great. So the local outbreak control plan was published at the end of June. It's on the council website, and the plan summarises the key actions and priorities that remain the same. They don't change on a month basis, but because the data has changed, some of the services that are available through the National Test and Trace has changed. A full review of the plan is being conducted in November, and a refresh of the plan will be published on the website in December. And that's 6 months on from the control plan originally being published. So I think that is quite good timing to do that. And the plan aims to protect the health of Darlington through the following ways. Firstly, through very clear prevention messages, and work done to date to update committee on this element of the plan has been training on PPE, personal protective equipment, i.e. when to wear it and how to take it on and off, information and advice on hand hygiene and respiratory hygiene, awareness of the symptoms of COVID, and that changed as well. So making sure that there were very clear messages about some, as the clinicians learned more about the disease, making sure that there were clear messages given through NHS 111 and clear NHS messaging about what to look for in symptoms. So that was very helpful. In terms of workplaces, the COVID risk assessments have been conducted in workplaces, and that's part of the clear prevention messages as well. The second bullet point on this slide talks about another key plank of the plan is for rapid detection of outbreaks. And I appreciate that some of you have been heavily involved in outbreak management in the past, and certainly you will want assurance that early detection of outbreaks is happening, and you will want assurance to know about what's being done about them. So we find out about outbreaks in Darlington in a number of ways, largely through the NHS test and trace system. We get notification that from the positive COVID test that someone's had, we do the backward look as to where they've been or where they've been working or where we think that transmission came from, and then manage via an outbreak response group, manage that. An outbreak is generally not closed down before 28 days. We want 28 days clear to understand that that outbreak has been managed and is closed. And as you can imagine, there's a very robust recording system and audit system around that. So in Darlington, Ken Ross, as Public Health Principal, chairs 2 outbreak response group meetings a week, and that is accountable and fed back to the Health Protection Board. The other way that we find out about outbreaks in Darlington is local intelligence. And I think I stressed this last time I was at Scrutiny Committee Chair, which is the role you all have as elected members in alerting the public health team here, in alerting me as to what you're seeing and hearing in your community. Some of this might be rumour, some of it might be anecdote, but I don't care. I still want to hear what you're hearing and seeing so that we can find out early if there is an issue that we can support or that we can help with. And that has happened quite a bit in Darlington, where we have known about and have been dealing with an outbreak before we've been officially told and informed. And frankly, I think that's one of the positive and one of the benefits of the way that we work in Darlington and the size of Darlington and the partnerships in Darlington. And this is my opportunity to say officially to thank you to Tuve, and Jennifer's on the call, to Sue for CDDFT, for Health Watch, and all of the councillors who make sure I get to hear what you're seeing and hearing, and I hope that continues. The third bullet point in the plan of the main aim is controlling onwards transmission. So someone unfortunately has COVID. What we have to do is everything we can to support that person in not transmitting it onwards. That's very difficult in terms of households. The majority of our transmission source, the majority is attributed still to household transmission. So someone has maybe been at work, they've come home, and that they've had it, and then it gets passed on to households. And I'll say a bit more about that when I give you a very brief overview of the ages and what we're seeing in the age bands in Darlington. So we provide advice about self-isolation and carry out the measures already described under number 1 of clear prevention messages. We want to build and apply intelligence. We get a lot of data. We get so much data from a range of different sources. And it's very hard to explain sometimes the fact that so many bits of the data are at different time frames, from different weeks, from different days. They're not necessarily calibrated in the same way, but we have to look at all of that information and get the best sense about what's happening in Darlington. We get, for example, information about our cumulative positive results. We get information from Public Health England about new outbreaks. I've already mentioned our local intelligence. We get information from Test and Trace. And we get a daily sit rep from the NHS. And as I say, the local intelligence is so key. Thank you, Paul. The third slide is one that we have a look at every day, what our cumulative cases are. And it is no longer really that helpful to look at the actual number of cases, but it's still very important maybe to have that historical picture. So the grey thing that I like to think of, like it's almost like a tsunami, the grey shading is the cumulative number of cases to date, and that includes people who were very ill and in hospital but were discharged. It includes people who were very mildly ill and got better. And it also includes, sadly, some people who have died from COVID. But at the time when this slide was prepared, our cases cumulatively were about 1,560, which is reflected on this slide, and our 7-day rate, so our number per 100,000 people, was 282.8. Since that slide was prepared, our numbers and our rate have increased, and today I'll just report to you I'm looking for my number here. So today we've just gone over 1,600 cases cumulatively, and our rate has just tipped over 300. And that is significant because these are the things, the rates particularly, that the government look at and the Chief Medical Officer look at when they do their silver and gold command meetings. Paul, can I have the next slide? And the next two slides are going to show you a bit more detail about the ages that we're seeing. And this is part of our intelligence. This is part of our understanding of how it is affecting different age groups. So it gives us a snapshot from September the 24th through to October, nearly October the 15th. And the colours, the dark, I think basically for me anyway, the darker it is, the bigger it is. So you will see that from September through to as of now, our biggest transmission are in the age group 16 to 29. We will always be vigilant and have concerns. Well, have concern about everyone actually, but we always will be vigilant and have concerns about our over 65s. And the impact there is to be thinking about when there is an outbreak in a care home or amongst some of our most vulnerable in the over 65s, we watch like Hawkeye what that top group, what's happening around that top area there of that top age band. But I'm going to move to the next slide and give you some headlines about what we're seeing. This is similar to the one you've just seen, but it's expressed in a slightly different way. Some people like to look at data in one way and others another way. So this is just showing you very similar data, but in a slightly different way. I must admit I had to get a magnifying glass and have a really good look at the colours, but essentially this is showing you in different colours. The 0 to 17s is kind of a darkish blue. The 18 to 22-year-olds is a kind of orange. I can hardly even read it myself. The 23 to 34s is the grey, and so on. And
Mary,
sorry, mate?
Sorry to interrupt. Can I ask why the age groups are different on both slides?
They're produced by different groups. They're produced by different organisations.
Right, okay.
That's the answer I can give you. They're not produced in the same way by the same organisations. But what I find useful in this one is you've got the over 75s. So you can see on this slide, I'll just give you the headlines. This is the average number of people in that age band over a 7-day rolling period. And the takeaway message I want to give you as a committee is to be aware that it's in our working age adults that are driving most of the growth. So it's not, we're not seeing huge numbers of over 75s. We're not seeing huge numbers of students. If you look at that group, we're actually, they're the two that are more or less the 65 to 74s, and the students are at the bottom. They're more plateauing. I certainly wouldn't want to say with confidence, Chair, that everything is flattening, because it's not in Darlington. In some parts of Tees Valley, there are signs that there is some of that, particularly in Middlesbrough and Hartlepool, but they had their peaks higher earlier than us. So the takeaway message of why I wanted to include this slide, and I'm not using a lot, but I wanted to include this because it does give you a view, and it gives you a way of seeing where the main growth is coming from, and where we may get some plateauing or some reduction. Paul, can I have the next one? For those of you who are aware of the local control plan, who've read it, who have looked at it carefully, and I know many of you have, you will be aware that in the plan we've had to set out how we would support particular settings. And our settings include care homes, schools, workplaces, and then generally all our community. Our transmission sources across these settings, I've just said in an earlier slide, are still mainly attributed to households. And that's we're given that as a big attribution. But I want to know where people have been when they're coming into the household. It doesn't just happen in a household, it has to come in some way. So what we're looking at here is, first of all, with care homes, local working arrangements are strong. I know Christine Shields is on the call, and if you'll forgive me, Chair, I just want to say thank you to her team of people her brokerage team who are in regular contact with the care homes, do an excellent job. And we also have good support from the infection prevention control team and the district nurses also from CDDFT. So there is a strong system of support around care homes. Nevertheless, it is a setting where if COVID is in a care home, it can be extremely serious. And we are dealing, along with every other local authority, we are dealing with some outbreaks in our care homes. And we have been very fortunate that these have not been at some of the scale that we have seen elsewhere, but it is a setting that we will keep extremely vigilant. The second one I just wanted to give you assurance about is schools. And I appreciate there will be, at the Children's Scrutiny Committee, there may well be a lot more detail about schools, but they're well organised. COVID is causing disruption as children have to self-isolate, but they have managed that around bubbles. And with half term coming up, it will give them a break and give them a respite. So they are managing. Workplaces, I've already given you the message that it's in working age adults that we are seeing the bulk of the growth, that we're seeing the most significant growth area. And in workplaces, there is support through two groups, officer multi-agency led groups within the council. And there is a group called the Prevention and Compliance Group. And that has the support of fire and rescue, police and environmental health officers who are able to very quickly, and that's again one of the benefits in Darlington, I think, very quickly contact workplaces to provide support and information. And are feeding back that compliance in that sector is high. Where I have seen through our contact tracing, where some cases have occurred across workplaces, one of the key messages that is coming out, some of the learning is around car sharing. So car sharing to workplaces, car sharing to sporting events or exercising or football. This is one of the issues, and there are equity issues in addressing that as to how might someone get to their place of work if they can't share a car or can't do that. But that is one of the things that we're finding. The final one is around communities. And there are places in Darlington where there is a higher risk, and there are individuals in Darlington who are at higher risk of an outbreak and the effects of COVID. These include workplaces or sites, might not be a workplace, where there are many people in the one place, or where they're in quite close proximity, or it may be people who are vulnerable because of other conditions they have, or their ethnicity, their age. So we have to be very aware of this. And I think going forward, one of my recommendations, Chair, will be to have a much higher focus on community engagement and understanding those different parts of the community. I haven't gone into the legacy of the hub and supporting people who need to self-isolate, but this may be something, Chair, you would want in your next update on the local plan at Scrutiny in November, it's December the 16th, which will be, there are some early signals from government about shielding and people who are clinically extremely vulnerable. And there is already work through Professor Kanunga and some across Durham County Council and Darlington work looking at that as well. Last slide, please, Paul. Nearly last slide. Second last slide. So I felt I should mention test and trace. It's such a key part of the plan. It's such a key part of the government's approach to preventing onward transmission, identifying cases and then managing them in the community. So you are aware of what the test and trace service is. This is one of the key ways that we find out about who has COVID and how transmission happened, and are there any postcode coincidences, and where were they, what was the workplace. So we get that as a notification and provide advice. We get information about the Pillar 1 testing. Just a quick reminder, Pillar 1 testing is the testing largely done through NHS settings. So through example, for people who work in the foundation trusts, for TUV, CDDFT, primary care. CDDFT opened their availability of testing to social care staff, and of course people who have to go into hospital and come out of hospital are tested through that. The Pillar 2 program are those tests that are done by post. They're tests where are at mobile testing units or a local testing site, and also the figures from the whole care home testing program go into that. So we get a lot of information from test and trace. You may have seen in the media some debate about whether local authorities could or should or might have the facility to do more localised test and trace service. And there is a huge debate about that. If you would ask me my opinion about that for Darlington, I would say we have good local intelligence, we could do with more, but it would need to be resourced and resourced significantly in order to run that locally. My last slide, and I was wondering about whether using this language about pandemic fatigue sounds a bit pretentious, but really I did recognise this when I saw it. I am using here some of the framework of work that's been done by the World Health Organization in encouraging communities to start, well, and their leaders, who are you, the elected members, to start thinking about how do you support your communities with pandemic fatigue. And some of the headlines of that, and what I'm very happy to do is send the link to Hannah with the notes. So for those of you who want to look up more about this framework from the World Health Organization, very welcome to do that. So this is around, what do you see in your communities? Do you see any demotivation happening? Do you hear the stories of people who have been so badly affected by the restrictions that we've lived with to date? So we are living with invasive measures in our lives, and it is important to acknowledge the impact that that's had and the hardship that people are experiencing around that. So what do we do? What can the strategies in Darlington be to maintain public support and in fact invigorate it, re-enthuse it? And it will come as no surprise that the World Health Organization research, first of all, starts with asking communities for their safe solutions to national celebrations, for example. Diwali is coming up. What might be some measures there that would enable that to be done safely? I'm sorry, but I am a Christmas person and I'm already thinking about Christmas. So I think there are some real issues there in your wards and with your constituency. What might some community ideas be about doing that safely and celebrating together safely? So that was why the bullet point of start early preparation was there. Asking people, you are well placed to collect the evidence and the stories of your constituents, their ideas and their creativity. Be clear in messaging. This is so important. Coordination to avoid mixed messages is key. We need to be as consistent as we possibly can and be honest when the message changes. If we can give a good narrative about why the message has changed. Be honest about the limitations of science and the limitations of government. That might sound a bit controversial, but it's around people coming together with their own solutions to be together safely. And finally, involving local groups in considering creative ways to reduce risk. So I felt it was important to not just give you an update on the statistics, the cases and the rates, but let's get thinking and planning with our communities about how to re-enthuse. Public compliance is going to be so important. It's about what's important to people. I'll leave it there, Chair, and very happy to take any questions. Thanks, Paul.
Thank you for that, Miriam. I just have one question. It's around the social bubble. So obviously they don't want to advertise social bubbling, but there isn't much educational pieces out there. And I know I've had quite a few questions around social bubbling. What is a social bubble? How can people social bubble safely? And when you look on some of the sites, it's not very clear. And I know yesterday I had a discussion with someone who thought that 3 people in 3 separate households could all bubble together, which obviously is not the case. So I do feel that we do maybe need to do a bit more of an educational piece on what is a safe social bubble around Darlington. Because I know that question has popped up a couple of times for me, and especially yesterday, and trying to explain it to someone is not the easiest thing to do either. So I do think that is a very important piece that we need to look at.
Thank you. I'll feed back to Neil as well. Thank you.
Yeah, no, that would be great. Is there any more questions for Miriam? Councillor Wright. Are you on mute, Councillor Wright?
Thank you, Chair. Can you hear me now? Yeah.
I can hear. Yeah.
Thank you. Hi, Miriam. I've just got a couple of questions. The first one is, do we know the figures of how many patients have contracted COVID whilst being in hospital care? I know that's been asked a couple of times to myself. And also, going back to the care homes and the outbreaks, obviously people speak and you hear whispers. Have we had some cases in Darlington where it has been a big outbreak? Because obviously we haven't had any information about that. I've heard of one on Bank Top, but I've just had no clarification yet. Thank you.
Thanks, Councillor. A couple of things there. Yes, I've been contacted by a councillor asking me if I know, if I could share the information about numbers of patients who have acquired COVID while in hospital. And it is helpful, I think, that Sue Jakes, Chief Executive, is on the phone. My response is and very happy to be further informed, but my opinion on that, it's really quite hard to attribute when someone became infected with COVID to one specific event. Now, you may well have a very clear opinion about that if someone has been in one residential, whether it's a hospital or a care home, in a particular ward for a number of, over 14 days and were tested negative when they came in and then tested positive subsequently. Very hard to attribute that right down to the source. Hospitals do have to report their acquired infections within that setting, and I'm sure when, I was going to say in the fullness of time, but usually it's quite a number of months in arrears that the audit committee who reviews those figures examines the cases. Now, COVID being relatively new and the testing regimes changing significantly over the last 6 months means we don't have that particular detailed picture to say, that person got that in that place, that person may have got that somewhere else. It's quite difficult to nail that down so specifically as to the source, the actual place where they may have got that. I think what we have to accept is that COVID is everywhere. It's everywhere in our community. It's a highly infectious and highly present disease. And that's why healthcare settings, including the hospitals, are so vigilant about the PPE and about changing the PPE regularly and about the regular cleaning regimes. Nevertheless, even with all those excellent practices in place, there are times, there are cases when COVID does spread. So I can't tell you exactly the number because I am not aware that there is a function that actually can determine that at this point. But I'm happy if Sue has got an alternative information to share. And Chair, Sue does have her hand up.
Yeah, if we could bring Sue in, that would be great. Thank you.
Yeah, I can get you the number, because you'll want the number, I assume, linked to Darlington, and obviously we've got the whole trust. I don't have that immediately to hand. I'll try and get it in the chat box before we've finished, or I'll get that forwarded on. But it is as Miriam described. So there is a technical definition that if somebody has been in hospital for over 7/8 days, there's been a slight change to the way that's counted recently, that we assume they have acquired it in the hospital environment, and we're all required to report on that weekly. When we report on it each day, if we have any of those cases, we undertake a review to try and establish if there's been any breakdown in procedures that we have in place that are aimed at avoiding it. But as Miriam says, it can often be very difficult, because in an isolated case, a patient will be having visitors as well as, seeing the hospital staff. And whilst we have rules for PPE for visitors too, it's impossible to absolutely say how they've contracted it, but they are very low numbers. I'll try and, whilst we're in the meeting or shortly after, pull those out for Darlington, perhaps the ones since September, if that will help you.
That's great. So while you're on, just a quick question for me as well. Is there any plans to utilise the community hospitals or even the Nightingale Hospital, if the cases do increase, to take those who are infected on wards and put them into a secure setting with experienced staff around COVID?
Yeah, so at the minute, what we've got 17 patients that are COVID positive in Darlington, and what we have in Darlington is a COVID ward. So we keep those patients together so that they can benefit from those experienced staff. We don't readily move patients with COVID either between or within hospital, because even moving somebody who's infectious brings in an element of risk that we try to avoid. We don't know what's going to happen with the numbers in the fullness of time during this wave or any subsequent waves. So we do have plans that link to our winter planning that identify how we would open up additional beds within the trust if the capacity that we've got is likely to be overwhelmed. So that the idea of the plan is such that it would never get to that situation, and that does include opening up extra beds in the community hospitals and Bishop Auckland, which is has some community facilities, but it is also an elective hospital, and it matches pretty much the plan that we had back in March, April, when we were able to stand up about 330 beds, although we never needed to do that. So we've back from that first wave got things like the physical beds, the lockers, etc. And what we would need to do in that circumstance is to have a level of redeployment of staff. So we've got a plan for winter. We know that we're going to have to deal with COVID and other things. We can expand significantly our capacity and would do so. That does involve expansion of the facilities that we've got in community hospitals and Bishop Auckland. And we do have a regional plan that if all of the hospitals were exhausted of beds across the whole region, the Nightingale is there and available. I think from what we're seeing at the minute and what we saw back in the first wave, it was a long way from being necessary to open that, and there are certain advantages in keeping staff in the locality in which they often live and work, and open up beds that are more local for residents.
Brilliant. Thank you. And can I say, Sue, what an amazing team that you do actually have.
Yeah.
You know, they all reacted really quickly in the first wave, and they're doing such a fabulous job now as well. So massive well done to you and your team. Thank you.
Thank you. I'll make sure that gets passed on.
Yes.
Absolutely.
Hello, thank you, Chair. And thank you, Miriam, for this lovely, good report. It's very impressive, and particularly Sue there, who seems to have everything under control. Keep your fingers crossed, Sue. Just two things to Miriam, though: intelligence and the message that we need to give out. Taking intelligence first, living in a village, one would assume that it's quite relatively straightforward to keep your finger on the pulse to find out what's going on. But I think the problem we have in the villages, probably like everywhere else, is rumour. And I've experienced that going into church on Sunday to be almost not an avalanche, but people talking about, we got COVID in the village, which of course creates a lot of concern, particularly among the older people. So trying to get to the bottom of that, it is very, very difficult. I set out yesterday to write a report for our local free paper in Newton Aycliffe, which gets circulated all the way through. But I find the information I was continue writing was getting contradicted by the time I'd written it. So what was deemed to be an accurate report, I found I couldn't really prove it, so I had to pull it, which I haven't had it printed. But for example, it's difficult to get information from our school. We do know there is a problem in the village school. Difficult to find out just how bad, good or indifferent it is. A care home, I am responsible for a resident who has dementia in Darlington. They're very reluctant to tell us what's going on in the care home. When we do find positive cases, we find that, touch wood, majority of these people have been proved checked positive, but they have no symptoms. So in one case, we have a guy who's 80-odd-year-old who one would assume would be really, really ill. He's as fit as a flea. I went up to see him on Thursday, and he's fine. So again, it puts complication it adds to the complication of the seriousness of this, particularly among the younger people. So whilst I'd have loved to send intelligence to you, Miriam, it does concern me that it would be inaccurate, so I don't see much relevance of it. Now, moving on to the message, I don't know if it's just a Hyington thing or a West Ward thing, but people are just fed up. And this sounds absolutely terrible, and I hope I don't upset anyone by this, but people are, well, the people I speak to, and I'm one of them, who was fed up of listening to the difficulties and the hardships of people who are experiencing COVID. I think we are in it all together, and difficulties and hardship now has become an accepted part of this horrible pandemic. So I think what we need to do is to be starting to feed some positive messages, because we listen to the main BBC news every night, and the news is virtually the same every night, which is a repeat of finding somebody who lives in Bolton or Bradford or Timbuktu and listening to how difficult they have not seeing the grandchildren or seeing the grandparents or the own parents who are in the care home. And it is difficult, I don't want to underplay that, but all this really doing, it's getting particularly the elderly people more and more worried, more and more concerned, and it's just totally ongoing from every source. And it's time somewhere along the line we start feeding out a positive message. And I would like to think that it's from the Borough Council's point of view, we can do that. There may be few and far between, but I think we've got to move now. We are all aware of the hardship. We are all aware of the difficulties. We are all aware of the terrible tragedies and sadnesses that we see and have seen. But we need to see a light at the end of the tunnel. And I would like for all councillors and all leaders to be concentrating on that aspect, however difficult it may be, because we need to lift people and bring them forward now and bring them out of the gloom. We've got another 6 months of it, we are told. Let's try and ease the pressure on so many people.
I couldn't agree more.
Chair, can I just respond to the first bit? Thank you. Sorry, Chair. And I think the last points you've made, Councillor Lee, reinforced my last slide, which was a call really about addressing pandemic fatigue, whether you use that language in the future or not. Could I just say very quickly, Chair, in response to Councillor Lee's first comments, assume there is COVID in Hyington, assume there is COVID in the school, assume there's COVID in the shop. And therefore, the messages are very clear about vigilance of social distancing, not mixing households, and scrupulous hand and respiratory hygiene. Don't be thinking it's not in my ward. It is everywhere in the community, and that's why those very clear messages apply to everybody. But I am grateful for the efforts you're making with your the people in your church and the people in your community around that reassurance. But just to be clear, it is in the community. There's nowhere that you can say, oh, well, it's definitely not here. It's not going to be in here. So that was my response to that one. Thank you, Chair.
Brilliant. Thank you, Miriam. Councillor McEwen, if I could bring you in now.
Thank you, Chair. Just a couple of points on the COVID fatigue. I think it is present. I picked that up as a community leader, but also on a personal level. This is different to March. The sun ain't shining, more uncertainty. So we as community leaders, ward councillors, have got a role to really keep reaching out to our local community. I think the second point I would make, and I might sound a bit controversial here, when we say we're in it together, I think different elements of the population are suffering in different ways. Young people, for example, you know, we have a prospect of significant youth unemployment because of what's happening, particularly in hospitality. You know, I'm all right apart from the sort of social side, you know, the difficulty in seeing grandchildren. So I think we're all experiencing it in different ways, and I don't know what the answer is. On a more specific note, I do have concerns around residents in care homes or sheltered housing, and I had a very distressing letter. I know it's featured elsewhere. I had a distressing letter from a lady in a sheltered housing unit in my ward, but she wrote to me as mayor just about, you know, her feeling of total isolation. So I'll be reaching out to Pauline to understand if I can go visit, even stood outside to talk to her. She is in a support bubble, and Pauline's probably aware of, or members of her team are aware of the case. So there's no question here. It's more I think as ward leaders, and Gerald's highlighted it, we need to keep our antenna up and keep speaking to the community, because I suspect that the COVID fatigue and the anxiety will start to present itself more and more as the nights draw in further, and it gets more, you know, the horrible weather that we're probably going to have over the next few months.
Yeah.
Okay.
Thank you, Councillor McEwen. I couldn't agree more. I know it's obviously hit the hospitality sector in Darlington pretty hard, but it's at the same time, it's good to see that Darlington's actually responded really well to Tier 2. But obviously we don't want to scare them off to the point that they're not using our hospitality in other sectors. So yes, I agree. Councillor Heslop.
Yeah, this is not really for Miriam. This is more of a comment on what Councillor Lee said. I'm very concerned about the fact that he sort of wants to, he appears, and he said this before in Scrutiny, to put the people who are suffering, grandparents, who are often the main carers for children, not being able to see children, you know, young people losing jobs, people getting 2/3 of their wages, you know, and expected to, you know, they're not getting 2/3 less bills. Now, I'm just making a point that I think it's a bit sad that Councillor Lee feels offended that the BBC are reporting the human face of suffering of this disease. And if he really wanted to be offended, he might ask his own party to up their game. That's all I wanted to say. Thank you.
Thank you, Councillor Heslop.
Welcome.
Any further questions on the outbreak plan, or can we move on? I'm just conscious of time. No, that's great. If we could now move on to item number 5, which is the tenancy policy. It's a report of the Director of Economic Growth and Neighbourhood Services, and it's pages 7 to 30 in your packs.
Thank you, Chair. This policy is around council tenants, so it's the tenancy policy in relation to our own stock, and it's the whole idea is that it helps us make best use of our stock and also helps us target those people most in need. I think you'll be aware that council tenants have long-term security of tenure, and it's often been known as a lifetime tenancy because essentially it's unless a tenant breaches one of the conditions, they can't be evicted. And so with that in mind, the government brought in the Localism Act in 2011 to give local authorities flexibility to provide some shorter term tenancies. The whole idea being that, you know, there is a shortage of accommodation, which is more acute in some areas of the country than others. And at the time, it was said that you could have fixed term tenancies between 2 and 10 years, and we introduced 5 years in Darlington. And you can see in paragraph 9 the different types of scenario where we introduce those tenancies. However, we're 8 years on in terms of introducing these flexible tenancies, and we've only got 150, and that equates to about 3% of the stock. We've had, you know, very limited take up right across the country from local authorities and social landlords, so we're not alone in this. It just doesn't seem to be a particularly popular policy or particularly applicable to ourselves. So we've reviewed it and we're proposing that, with the exception of properties that have been extensively adapted, so for instance a additional room or something like that, or properties in areas of regeneration where perhaps properties have been identified for demolition, but we want to let them on a short-term basis so it doesn't blight the area. So it just gives us that bit of flexibility, but doesn't impose the sort of stringent measures that we've got at the moment, bearing in mind that we've never refused somebody a permanent tenancy in the 8 years that we've had this policy in existence. So there is more detail in the appendices, and I'm happy to take any questions from members.
That's great. Thank you, Miriam. Sorry, Pauline. Miriam's had to drop off the call. Is there any questions for Pauline on the tenancy policy? No, I don't think there is. Let me just double check. No. Okay, thank you, Pauline, for that.
Yeah, thank you.
If we go on to item number 6, so the Preventing Homelessness and Rough Sleeping Strategy update, report from Neighbourhood and Economic Growth.
Okay, yes, that's mine as well, thanks. So originally this was just going to be about reporting the progress we'd made on the homelessness and rough sleeping strategy, but clearly homelessness services had a huge impact in terms of COVID, so the report covers both issues. So just running through some of the impacts first of all that the pandemic has had. The demands within homeless and housing options service has been very significant, and normally we would have liked to have been very proactive in people who present to us, and you know, in this particular instance we've had to be reactive quite often, so that we can ensure that no one was left homeless or having to rough sleep. And obviously I think members are very much aware that the risk of infection from people who are homeless is so great that we couldn't allow that situation to happen. So the government came along with this idea of everybody in, and that's something that the council adopted, that anyone who presented as homeless, regardless of their needs, was placed in emergency temporary accommodation. So generally speaking, the type of accommodation we use is a mixture of temporary council housing, emergency supported accommodation, and out of area placements where it's necessary. For the first 3 months of this year, well, up until the 31st of July, we had to supplement that with a range of different options around bed and breakfast and a local hotel, but we've ceased using that at this moment in time. So I think the issue for us was that whilst the number of people presenting only increased 12%, the real challenge for us was the number of nights that people stayed, and there was a number of reasons for that. One was that quite a few people had quite a few high needs, complex needs, challenges that meant they were difficult to place, and obviously just the sheer volume of people. So you can see in paragraph 8 that for the first quarter we had 1,451 nights in emergency accommodation compared to 232 in the same period. We also had a 153% increase in the number of people placed in out-of-area accommodation, and we had 65 repeat presentations of those individuals who were entrenched rough sleepers. Just want to sort of reassure everyone that everyone in need of emergency accommodation was provided with somewhere, and most of the people that were in those emergency accommodations have now been moved on to permanent housing. We provided a bit more detail in tables 1, 2 and 3, but I don't intend to sort of go into that detail. Jeanette McMahon's on the line as well, and I think if Chair, you're okay with that, I'll stop at this stage before I go on to the strategy to see if members have any questions on that particular element of the report.
That's absolutely fine. Any questions for Pauline? No, I think we're fine to move on, Pauline.
Great, okay, thank you. So just moving on to the strategy, which Cabinet approved in July last year. You can see from paragraph 17 that there was 5 key supporting objectives to the strategy, which I don't think will come as any surprise to anybody. But the particular emphasis for some time now has been on prevention, and the Homeless Reduction Act of 2017 brought in some new challenges around greater cooperation across agencies, and that sort of recognised that we needed to take a holistic approach to assessing needs and finding solutions, that it wasn't always a housing solution, but it could be, for instance, a mental health or issues with drug or alcohol. Lots of different organisations need to be involved. So we set up a new monitoring group to help focus the coordination. And we've attached at Appendix 1 how far we've got with our strategy. So there's 28 actions in total. 9 have been completed, 12 are progressing and are on track. And there's only 7 that, whilst they're progressing, they're not quite on track. And that's mainly to do with housing related support contracts, which the commissioning team in People Services is responsible for, and clearly you'd be aware that they've been focusing on other issues over the last few months. So that's the reason why those particular actions haven't been progressed as timely as we'd originally anticipated. So again, happy to answer any questions members may have.
Any questions for Pauline? Councillor Lee.
Hello, Pauline, and very, very well done on a very, very difficult subject. From my limited experience, and it is very limited with the homeless, I did tend to find, I have found before, that a lot of people wouldn't pay you to go into any accommodation on a night. They're quite happy to sleep rough. And even when they did so, and we got some pushed into the lodge, they were more than keen to stop 1 or 2 nights and then revert back. How have you managed that? How is it fair to say that most people who you have rehoused are content to stay there?
Jeanette, do you want to come in and answer that particular question, because you've been a lot more involved than I have?
Yeah, I mean, the lodge are are excellent, because obviously the 700 Club run that, and they're
Yeah.
obviously got a lot of support around that. So we don't just look at the roof over the head. We look at what support that person needs. And you will get some time that people don't engage, and it will sometimes take years before people will actually come in and engage with us and sort of address their issues, as it were. But I haven't had any bad feedback about the lodge. I think everyone who's been in there is they are some complex needs people, and that's why sometimes we have to place people out of area who because there's specific accommodations set up for different needs. But also we have the excellent sort of pathway, as it were, so people move on to the hostels and taught that independent living and everything like that. So you'll get people who won't want to engage, but hopefully if you keep on working with them and each time they do present, look at them differently, let's see what the issues are this time and give people opportunities each time. So it's sometimes a complex issue, isn't it? But sometimes you just have to look at each presentation differently each time.
That's great.
Well done. No, all we can say is well done. It is a very difficult problem. Thank you.
Brilliant. Thanks, Councillor Lee. Any further questions? Councillor Donoghue?
Oops.
Oops.
Oh, I'm back. Yes, Polly. Do we have many, if any at all, rough sleepers in Darlington?
At the moment, we have a commitment to have, well, we always have a commitment to have no rough sleepers. In the past, we have had a couple of very well-known ones. I don't know whether you're aware, but there is a group being set up for the last probably couple of years around begging, and the two individuals that people felt were rough sleeping were actually beggars, and it took a multi-agency approach over many months, and given them many opportunities in places like the lodge and so on, before they were moved on. And I don't know whether they're still around at the moment. Jeanette, are they, or have we successfully moved them on at the moment?
One of them has gone out of area, and one of them is living with their daughter at the moment. Yeah,
there was I was in town on Saturday. There was a chap which I've seen a few times who was begging for £2 at a time so he can sleep in Victoria, that place in Victoria, the hotel in Victoria Road.
Right. Okay.
I've seen him a few times on a weekend.
Yeah, we have an outreach service, so we go out and talk to each individual and see if they are, because at the end of the day, we try to establish which ones are vulnerable. But the likelihood is a lot of people do have accommodation but choose to beg. So it's then establishing the reason why they're begging. So do they need that support? Do we need to look at anything differently for that person? So we generally do know who the people are who beg, but it is good. There's a street link. So the members of the public can report them through, and we will go out and talk to those individuals if we know about them.
Yeah,
lovely.
And I know if you do see anyone in town, I know I've contacted the enforcement team before who've gone out to ring the emergency social service number to offer them accommodation. So sometimes the enforcement team are really good at doing outreach on night times, especially. To offer that emergency social service number, so that is also a good option. And I know I've offered it myself to ring the emergency number for them, but sometimes they just don't like to. Don't want to go to the accommodation offered. So but no.
A homeless officer will be on duty 24/7, so you can always get through to someone if you need to, and through that number. Yeah.
It might be worth sending that number out to all councillors so they're aware of it, actually.
I was just going to say that.
It'd be really good. Then we're like outreach workers ourselves, aren't we, really? So, it'd be good.
Yeah, I can send that to the group and everything,
Lovely, thank you.
Councillor Heslop, can I bring you in now, please?
Thanks, Councillor Bell. Sorry, I just wanted to go back a little bit to Table 3, left hospital or prison. Mm-hmm. If the people are leaving the mental health hospital, I would have thought that there would have been sort of discharge planning, therefore accommodation would have been taken into account. And also, by the same token, if people, for whatever reason, are leaving prison, I would have thought that as part of risk reduction, there would have been formal arrangements for people to have accommodation. So it was basically just to have if you could tell me a little bit about the figures and the bottom line about the 18 people connected, if you don't mind. Thank you.
It might. Sorry, do you want to?
Yeah,
all right,
you
Margot.
go
Yeah,
first,
it might be that we knew about those people, so that would be a planned approach. So we have some good relationships with the prisons and with the hospitals. So the prisons we do through the gate service. So they would do their needs and risk assessment for us. So we would plan where that person is going. So some of them figures will include those planned approaches, but they have actually come out of prison. Mental health hospital again, they generally have meetings prior to someone leaving, so generally we do get invited to them. There might be one or two people who do slip by the through the net, as it were, and even though sometimes you plan that prison release, they don't present to us, so we don't capture them, and they might come to us at a later date. They might have like a week where they are just they disappear and then they come back to us. So a lot of them will be planned, but there will be, realistically there are sort of one or two people who do come through and present to us, but generally we have a good robust sort of service for those.
Yeah, okay, thanks very much. Cheers.
Thanks, Jeanette. Thank you for that. Councillor Tostman, if I could bring you in now, please.
Thank you, Chair. It was really just to reinforce what Councillor Donoghue was saying, that there is a gentleman on Saturday evenings in the square around about Uno Memento area who's begging for money for his breakfast. Was approached a couple of times by him on Saturday evening. But I think the idea of circulating the number to the councillors is a good one, so that we can actually get in touch with somebody if we see that again. Thank you.
I'll get that inspected as well.
Thank you.
And on the back of this, I know obviously isn't there a rule in Zone 1 in Darton Town Centre that they're not allowed to do that? So how do we approach that with them, Jeanette? Do we know?
So community safety would probably do those pieces of work for us, and then refer it back through to us. So again, if I send some of the numbers through and we're aware of it, because they would do some of the patrols and everything.
Right.
But generally, our outreach where they can, they will try and visit on, sort of go and see that individual as well.
Yeah.
So as I say, I'll send you some numbers through so you know sort of what to contact, and as we'll just make sure that that's, that at least if we all know what we're doing and all knowing who to contact, then hopefully we can sort of resolve these issues.
Yeah, no, that's great, thanks. Any further questions for Pauline or Jeanette? No, that's great. Well, thank you very much, ladies.
Thank you.
Let's move on to item number 7, which is the crisis service changes update. This is a report of the Director of Operations, Durham and Darton, TS Weir Valley NHS Foundation Trust, and it's pages 41 to 42 in your packs.
Okay, so you happy for me to take over, Chair? Yeah.
Yes, Jennifer, that's great. Thank you.
Okay, thank you very much. Okay, so you've just got a brief paper there. I think the title of the paper is about the crisis team, the service update or the changes to the service, and I guess this probably relates to earlier this year when the Darlington and Durham crisis teams have come together into one consolidated team. So I think you'd been briefed on that probably when I just started my role. So just to give you an update on that, and then just there's some more detail in the paper about some things that have happened through the pandemic. So what we did have previously was a crisis team based at West Park Hospital in Darlington, and then we also had a crisis team based in Durham at Lanchester Road Hospital. And now what we have is a combined team they're based in Bishop Auckland. So we have what we call a crisis hub, and we brought the two teams together for various reasons, but mainly for efficiency of having all the teams together, because we can never, the workload isn't always easily spread across the two patches in our locality. So it's to allow that flexibility of the team. And the team has been working that way now since the middle of January. However, to be fair, we were going to do an evaluation of the working of the team, but because of coronavirus that came unexpectedly to us all in March, that hasn't yet taken place. But I guess what has taken place throughout the pandemic is some really positive work with that team. And we've also been fortunate enough to receive some non-recurrent funding from our commissioners. to try and bolster the team, because the thing that we have recognised through the pandemic, certainly towards the end of wave 1 and now that we're into the second wave, is the crisis team is really busy. We've had our, the contacts of the crisis team is more than it normally would be. So what we need to do really is to try and make sure that we manage that safely with enough people. So we've got some adverts out now to recruit some enhanced staff. But what we want to do also is to try and keep people out of hospital wherever possible, because we have had some instances of coronavirus in West Park in Darlington. We don't have any touching the wood of my table. We don't have positive patients at the moment, but we have had to have a separate ward, which we've now been able to stand down just from the weekend. But we're on red alert at the moment, I guess, for if that happens again. So it is very resource intensive on staffing. We have to move staff around, and we have also got quite a lot of staff off who are either COVID positive or have been in contact with somebody who's COVID positive, because as Miriam alluded to, it's in the community at the moment. So going back to the point I was making, is that we've got some non-recurrent funding to enhance the crisis support and the home-based treatment that we can give to our service users who may be in need at that time, to try and work with people more intensively at home and to keep them out of hospital, which will reduce the risk of hospital infections of coronavirus at this time. But also, home is the best place for people to be if they can be there. So that's a really positive thing. So we're really pleased to get that funding, and we're hoping to be able to keep that going through future years if we can prove that it's been worth its while, which I'm sure that we can do. The other thing that we've done through the crisis team is we've been working with NIAS, so the ambulance service, and we've done a pilot, which we've just got the funding to continue that. So what we're doing is putting a mental health nurse in a car, so that if NIAS get called to what they know is a mental health crisis rather than a physical health crisis, although sometimes they are both at the same time, the mental health practitioner goes with the ambulance practitioner in the car, and that's proven to be quite good at keeping people out of hospital, keeping people away from A&E, which is something again that we want to try and do through this time. But to be honest, a lot of the things I'm talking about that we're trying to do because of the pandemic, it would actually be good practice to do that anyway. Outside of that, we want to keep people away from accident and emergency. We want to keep people at home as much as we can. So these things all help us towards where we want to get to. The other thing that we've done through the summer and through the pandemic time is work again with NIAS for the 111 line. So the 111 service that I'm sure you'll be familiar with is something that you ring if it's not a 999 emergency, but you might want to get through to get some help. But there's now a mental health stream to that 111 line, and where we are manning that bit of the line. So that again has proved very popular with people ringing up who might not be in a what we would define as a mental health crisis, but might have a lower level mental health need. So that line is very well supported. It's also got a branch to that line, which is a listening line. So if people just need to talk and just need somebody to talk to, it's got that listening branch, which I think is very well received and has been very well used through the pandemic. And lastly, that's not quite in the paper, but probably should have been, is just that we've introduced over the summer a 24/7 single number for crisis, so that if people ring crisis in the old days or in pre-coronavirus days, you would have to ring an adult line for adult crisis, you'd have to ring a children's line for a children's crisis, and you'd have to ring a different number if it was an over 65 person's crisis. So now we've brought that all together into a single number. So you ring one number and then you've got an option to press, a bit like if you rang a call centre. But that again is proven popular. There was a few teething problems, as there often is with some of these new initiatives, but that is also being received very well. So I guess that's just a bit of a flavour of what's going on in the crisis team. Happy to take any questions on that.
That's great, Jennifer. And can I just say, when this first got presented to us, I know there was concerns about the streamlining of services, but from what Councillor Lee was saying earlier, I do think this is a really good news story that, during these times that you've been able to trial stuff, even having the representative in the ambulances and the new telephone service. So, it's really good. I think it's
kind of pushed a load of things forward so much quicker than we would have done if we didn't have the pandemic. So if there is a good thing to come out of the pandemic, and I'm sure there isn't much, but if there is a good thing, this is a good thing.
I think that's a really good news story. I really do. Thank you. Any questions for Jennifer? Nope. Great, thank you for that. So if we could move on to item number 8, which is the Right Care, Right Place. It's update report of Director of Operations, Durham Darton, TZESC, and We Evaluate NHS Foundation Trust, and it's pages 43 to 46 in your packs. Thank you, Jennifer.
Okay, thanks, Chair. So again, this is an update on our Right Care, Right Place initiative, which I'm sure you've had updates on before, because it's about 2 years in the making. So this is about how we make sure that our community services are in the right place for people, and they are inclusive, and they are, that we're not just dealing with mental health services here, we're dealing with what the community needs, and that will be the voluntary sector, that will be social services, it'll be, there are various strands to this piece of work. So I guess what you've got is a bit of a reminder in the beginning of the paper. You've got that picture there. I'm not looking at the paper, I'm looking at you guys. So there's a picture on one of the first pages, which is that was pulled together in consultation with all of our partners and stakeholders back in June 19, so a little while ago now. So that was looking at what would good mental health care look like for the community of Darlington. So, and that's a pictorial reference of that. And I guess what came out of that piece of work post that, so during sort of the summer towards the end of last year, was 12 priorities for us to work through with yourselves and other partners. And I guess they are listed further down in the paper, and our progress against them is also listed. So from the Right Care, Right Place initiative, we're probably in a very similar place to what I've just talked about with the crisis team. It has allowed us, although we haven't progressed as we would have liked in the way that we would have done if the pandemic hadn't have arrived when it did, it has allowed us to continue some work in the spirit of the Right Care, Right Place initiative, but getting things done a little bit faster than probably we would have done in normal times. So some of those ideas would be the support, the additional support we've put into our care homes locally, the access to low-level mental health support in working with the community hubs and the resilience hubs that are out there at the moment. And also, one of the things I guess that we're probably proudest of is the greater use of technology, and how that is, we've been allowed to progress with technological advances that probably would have taken years to get through in another world. So how we've been able to contact people far more frequently, keep in touch with people when it wasn't, we weren't able to do that face-to-face stuff back in March, April, May time. So and we are keeping some of that going. So, and that was all of those elements were sort of strands of the Right Care, Right Place work. So there is an update. I'm not going to go through it line by line, but there is an update against those 12 priorities, and some of that relates to the crisis paper that I've just touched on as well. So happy to take any particular questions on that. But just to finish on the paper is just, we are moving forward now at a pace about integrating our services truly with both the local authority and the voluntary sectors in Darlington and across the organisation, to be fair. But in the spirit of the community mental health framework that was published last year too, we are currently pulling together some multi-agency bids. So in line with, we have involved local authority and voluntary sector partners. In fact, we've voluntary sector partners to be leading on some of these bids, and there are going to be some transformation monies made available from the centre, and the date for the bids to go in is the 18th of November. So we're working really hard with partners to pull those bids together as we speak, and I can give you an update at a later date about how we get on with that and what kind of money, fingers crossed, that comes out of that and what we'll be able to spend that money on. So happy again to take any questions on that paper, Chair.
That's great, thanks. And it's great to see that this is coming on. I know obviously it's a difficult time at the moment to be focusing on that, but no, thank you very much. It's much appreciated. Is there any questions for Jennifer on item number 8? No? Right, well, thank you very much, Jennifer, for that. It's much appreciated.
Thank you. Thanks, Chair.
We've covered item number 9, so we'll move on to item number 10, which is the work programme. This has been subject to change over the past couple of meetings because obviously priorities are focused on COVID at the moment. Has everyone had a chance to look at it in the next for December? Is there any comments?
Chair, I've just got one comment. I've been asked by officers to move the customer engagement and housing services to the meeting on the 3rd of March, if members are happy with that.
I'm happy with that. Is there anyone who objects to moving that item? No, that's great. If we can move that, Hannah, that'd be fine. Thank you. Okay. There is no supplementary items from me. Is there any other business from anybody? No. Any questions? No. Hannah, could you let me know when the live streaming has ended? I just got an update for people, that's all.
Yeah, no problem.